Okay, so for coronary artery anatomy, we have our aorta, and right away, this blood is just newly oxygenated blood, right? Coming right from the pulmonary veins that was going to the lungs. And this newly oxygenated blood is going to go right to the heart. These vessels are going to come right off the aorta. You can see the right coronary artery and the left coronary artery. So these are the two major branches. Let's do the right side first. It's a little bit easier. So the right side, we have the single vessel coming down. So this branch right here, that's the right marginal artery. Okay, that artery is primarily going to supply the right ventricle, and it's going to kind of get over here to the cardiac apex a little bit. That's more of a left ventricle territory. But the majority of this is supplying the right side of the heart. The big structure to remember here is the sinoatrial node. And remember, that makes sense, right? The sinoatrial node is in the right atrium. And so the right coronary artery should be supplying the sinoatrial node. And this is one that comes up quite frequently, so make sure you're familiar with it. Now the left coronary artery, which we can see up here, it's going to break into two major branches. The first branch is going to be the left anterior descending artery. And if you had to remember one artery, this is the one that I would remember. It's probably the most high yield because it's the most frequent artery that has occlusions or results in coronary infarctions or myocardial infarctions. Okay, and so there's three major areas I would remember with the LAD. The first one is pretty obvious. I mean, most people know the left anterior descending artery is going to go down to the anterior ventricle. Okay, so it kind of says it in the name. The anterior 2/3 of the interventricular septum is supplied by the LAD. Kind of makes sense, right? So we have anterior, anterior. And the anterolateral papillary muscle is also supplied by this artery. Now you'll see that the second branch of the left coronary artery, okay, the second branch is also going to supply the anterolateral papillary muscle. So that's going to be this artery, the left circumflex artery. Now, just to kind of show you these in a little bit better detail, so the LAD you can see is coming straight down. Okay, so it's mostly going to the left ventricle, and then you can see the left circumflex artery is actually kind of wrapping around the side here on the back side of the heart. So it's going to some of the left atrium, because remember, what's the most posterior chamber? Why is it wrapping around there? It's going back to that left atrium, and it's also supplying some of the left ventricle. And again, also supplying the anterolateral papillary muscle. When you think lateral side of the heart, think about that left circumflex artery. When you're thinking more anterior left ventricle, you're thinking more of the LAD. I want to preface here, everything I'm saying is going to be classic pathology. So, technically in real life, left circumflex artery can go to the sinoatrial node. Technically it can do that, but we don't want to think about things with technicalities. We want to think about classic cases of what's happening, and that's what these videos are all about. So I just want to remind you that if you're sitting there and saying, well, technically this can do this, that's true, but we're trying to just think about, if I have a question on this, what would I do to, have to get the question right? What would I have to know? So the next thing I want to say is the posterior descending artery is a point for confusion for some people. So the posterior descending artery can arise from the right circulation or the left circulation or both circulations. So most patients, just like when we went through neurology, we said, hey, this, if they tell you the patient is right-handed, then they're left brain dominant. If they tell you the patient is left-handed, it's kind of hard to figure out if they're right or left because it could go either way. But if they don't say anything, you just assume they're right-handed, left brain dominant. Same concept here. If they don't say anything, you just assume that they're right circulation dominant because 80 to 85% are going to be right-sided dominant. So what that means is, let me just show you. So that just means that the right coronary artery is going to give off the posterior descending artery. And that's actually the case in this image here. So if you can see, here's your right coronary artery, and then it wraps kind of around back. And then this artery here, going posteriorly and inferiorly, that's going to be the PDA, or the posterior descending artery. So specifically, it's going to be like this portion right here. Okay, now you can see in this drawing, again, it's coming from the right side of the heart, so we would say this is right dominant. However, if this artery came off of the left circumflex artery, if it came off of here, okay, because remember, the left circumflex artery wrapped around back, right, and if it came off of here, then we would say that the patient is left dominant, and again, it can come off of both, in which case they'd be codominant. And the posterior descending artery is going to primarily go to the inferior border of the heart. The two big structures I want you to know, posterior 1/3 of the interventricular septum, as opposed to the LAD, which is the anterior, and then the posterior medial papillary muscle, as opposed to the left-sided vessels. The other thing that comes up here is people will say, well, you know, Dr. R, you didn't talk about the AV node. Okay, you said the SA node, but what about the AV node? Now, this is in the right atrium, right? So it's in the right atrium, so it's probably supplied by the right coronary artery. And I'd say, yeah, you're probably right. In most cases, it is supplied by the right coronary artery, but it actually kind of depends. Okay, so this is a point that comes up in board questions. Whatever circulation dominance there is, that will dictate who supplies the AV node, at least classically in board questions. So if the patient is right dominant, you can put your money on the right coronary artery supplying the AV node. However, if the patient is left circulation dominant, then you would pick left coronary artery as your primary vessel supplying the AV node. So just kind of keep that in mind. That's kind of a concept that comes up that's confusing for some people. And you can imagine, you know, if you have an infarction to the right coronary artery, you know, these patients are going to be at risk for arrhythmias. And you might be saying, well, why is that? Well, remember, the SA node is where we're going to generate our action potentials that are going to perform all of this electrical conductivity. If I have an infarction at the right coronary artery and knock out the SA node and, you know, potentially the AV node as well, that can predispose this patient to developing arrhythmia. So just something to keep in mind.